Hi, my name is Stephanie Velasquez, and today we're going to be evaluating a hip. Hi, I'm Stephanie. Can I evaluate you today?
Yes.
Alright, what's your name?
Alex Schultz,
Alright, how old are you, Alex?
18.
Okay, and what brings you in today?
I was at wrestling practice on the mat with one of my teammates, and he picked me up from behind, and we both landed pretty hard on our right hip.
Alright, and this is today, just recently happened?
Yes.
Perfect. Alright, so since my athlete came straight here, I'm going to approach this as an on-the-field evaluation. Obviously he hasn't treated it yet since this just happened. Okay, can I palpate your hip? Can I touch your hip? Is that okay?
Yes.
Okay, can you stand up? Okay, can you show me where the pain is?
Right here?
Right here, okay. Does that hurt?
Yes.
Okay, so he is point tender right along the iliac crest. I think that is from the impact of another wrestler landing on top of him. When I touch this, I do feel some swelling in there. Can you turn around so I can feel your other hip? Any pain on this side?
No.
Yeah, there's definitely a difference in bilateral comparison. The involved side has an increase in skin temperature. It feels swollen. It's point tender for him. Upon visual observation, I do see ecchymosis. You can go ahead and sit down. So knowing what I have just learned, that his mechanism of injury is a direct impact on the hip, he's point tender on the iliac crest, and he has bruising, I am suspecting a hip pointer. Typically with these, we're going to see a loss of range of motion immediately, and he's not going to be able to flex his hip, or if he does, it's going to be very weak, and it's going to hurt in abduction because of the affected muscles being the glute med, glute min, IT band, and TFL. Okay, so I'm going to go ahead and test your strength and your range of motion. So first, let's do range of motion. Go ahead and just lay down and put your head this way, legs that way. All right. Can you raise your foot up to the ceiling? Okay, it looks normal for the uninvolved side. Okay, now resist against my hat. Normal strength. All right, and this is the involved side, so I'm expecting to see some deficits. All right, foot to the ceiling. All right, definitely more difficult for him, and resist my hand. Okay. So he's definitely weaker on the involved side. Does that cause any pain for you?
Yeah.
Okay, and it's painful. Can you flip on your stomach, please? Okay, and we're going to do the same thing. Let's do uninvolved side first. Can you raise your foot? Perfect. All right, and now let's do the involved side. Does that hurt?
Yes.
No, it does hurt. Okay. And let's do resisted. Go ahead. Awesome. And let's do resisted on this side. Yeah, so definitely weaker on the involved side. I'm able to break him in resisted. So I'm definitely thinking because of the mechanism of injury, this is a hip pointer. I'm going to go ahead and do some abduction just to see his strength. Okay, so you're going to want to pull your leg out that way. I'm going to resist against you, okay? 1, 2, 3, go. All right, is that painful for you?
A little bit.
Okay, you can go ahead and sit up. All right, so considering what we know, he is weak in flexion, extension, abduction. He is point tender, and he has ecchymosis. I really do think this is a hip pointer. Aside from that, I think a differential could be maybe a fracture to the ilium, or possibly a fracture to his femur. That's something to consider just because where that trochanter sits in the acetabulum. So right now I'm going to do some bump and squeeze tests and see if that is painful on the femur. I do want to refer this patient out for imaging in case we do have something like that going on. We can even have an injury to the surgical neck of the femur, just want to rule that out before we move on in rehab. Today, because this just happened, I'm going to send him with ice and maybe wrap him just to keep his leg from moving into abduction, flexion, extension. Maybe pulling that knee in with a wrap over the ice bag. In addition, I'll probably give him, or just tell him to take NSAIDs if they're not prescribed. I know he can get those over the counter. Those should help with the excess building of edema if fluid does occur, or if metabolism starts to bring fluid to the injury site. Something to consider with this injury also is that bursa that's in the coxal joint. So when we refer for imaging, I would like to see if they can check for bursitis. If there's a hematoma or bursa that needs to be drained, I would like to know that we can aspirate that before we move on in the rehab process. So I'm going to move on and just try to rule out a fracture. Obviously, imaging is going to be the rule of thumb here, and the gold standard, but I want to go ahead and try doing that on my own. So go ahead and lay down on your back. Okay, and relax your leg. Does this hurt?
No.
No. Okay. Relax. Bend your knee. And here I would try to do like a bump with percussion all the way up his leg. Any pain here?
A little bit.
A little bit of pain?
Towards the hip.
Okay, so you can sit up. So, in an injury to the iliac crest, is my best bet that is very normal to have pain proximal to the hip joint where the injury occurred. The more distal you go, the less pain you're going to be feeling, just because it is not involving the femur. It's more involving the ilium and iliac crest. Okay, so some things to consider when you have an injury to the lower extremity is pulse and cap refill. With the hip, I want to check pulse and cap refill. With him, I checked it. Cap refill is within normal limits, as shown in my SOAP note, within 2 seconds. His pulse is normal. I think that helps rule out a fracture, just because if you do have a fracture, the body might create a stronger pulse as a result of the injury and the body trying to guard from the mechanism of injury. Moving on from vascular checks, neurological things to consider would be, obviously with the hip, the sciatic nerve and the femoral nerve. Because of where the injury is on the iliac crest, I'm not worried about it. If this were like a blow to his glute or to SI joint, I would definitely be considering checking those. I don't think that at this time it is pertinent to the contusion of the iliac crest. Moving forward in our rehab, if he has any neurological symptoms present, then I would definitely consider checking those again and referring for a physician evaluation. Some special tests that you could do with the hip pointer: you could do Ober's test to check for TFL tightness, which would be secondary to the direct impact on the hip. Muscles are going to guard in the contusion, so he will have TFL tightness. Other than that, with the iliac crest being injured, I want to send him with ice and just try to fight that metabolism and edema mechanisms that are already happening in his body.